Many of the patients that get admitted to me are in the emergency room with shortness of breath. At the time we see them, we don't know if they have heart failure or a lung problem. So is the cause of dyspnea cardiac or pulmonary? Maybe they've never had an echo here. Maybe we don't have any old history to say that they have heart disease or lung disease. So often in the emergency room, we're trying to determine which one it is, heart or lungs. You can use AI then just by looking at the EKG. Without waiting on that echo to be done tomorrow or the next day, you can know instantaneously whether it's the heart or the lungs. So acute dyspnea is common, right? We see it all the time. In this study, we basically trained the AI to look at an EKG and know whether or not heart failure is present. What's interesting about this is this performed better than BNP. So if you had a choice right now, let the AI look at an EKG or order a BNP, the AI would beat the BNP every time. You're like, no. I'm like, yeah. You're like, I don't believe it. It's true. AI was superior to pro-BNP to distinguish cardiac versus a pulmonary cause of dyspnea. So let's go into today's topic, which is AI and cardiology. And with regard to atrial fibrillation, what I want to talk to you about is the Apple Watch. So I'd like to see a show of hands. How many people have a smartwatch on their wrist right now? 1, 2, 3, 4. Okay, great. So the data I'm collecting on this is consistent, which is about 50% of the people in the room have a smartwatch on. In the US of A, about 45% of Americans have a smartwatch. That is, to me, amazing, how high that number is. Why that's important for us today is that this fact that we own and wear a smartwatch is an amazing opportunity to, number one, gather health data, and number two, intervene on improving patient care. And I'm going to demonstrate to you how that applies to cardiology today. So in 2019, Apple, through the New England Journal of Medicine and Stanford University, published a study called the Apple Heart Study. The goal of the Apple Heart Study was to evaluate the ability of an irregular pulse notification algorithm to identify atrial fibrillation with the use of an Apple Watch. So over 400,000 people participated. 0.5% had an irregular rhythm, which is just less than 1%. In spite of that, the number of people in this study is so large that we have really good p-values and really meaningful data to share with you today about this. If you screen positive on your Apple Watch for an irregular heart rhythm, then you were mailed a patch to wear, a monitor basically, you wore for 1 week to confirm that you have in fact atrial fibrillation. Only 1/3 of the people returned their patch when they were mailed a patch, which is low, 1 in 3. But in spite of that, the N is so high that we have good data. And so the patch would confirm EKG. The positive predictive value was 0.71. So this is the paper. This is a landmark study in medicine and cardiology and artificial intelligence. This was heavily discussed at the last Internal Medicine ACP national meeting in Boston. Let's go into how this works. There are optical sensors on the wearable device that can detect the irregular pulse. You need an app, a smartwatch app, to identify atrial fibrillation. Participants were notified if the sensor detected an irregular pulse. Then an EKG patch was mailed, and they were instructed to wear it for 7 days. And 90 days later, a survey was sent. There were over 400,000 patients, 419,297, over an 8-month period. They were monitored for 117 days on average. 2,161 patients, or 0.5% or half of 1%, had the irregular pulse. 450 of those returned their EKG patch, and the data was analyzed. AFib was present in 34% of those patients. Most were over the age of 65, which is not surprising. AFib is a disease of aging. 1,376 patients returned their survey. Half of those people then saw a physician outside of the study. So if you wear an Apple Watch, the chances of you detecting AFib, why is it low? Because who wears the smartwatch? Not the frail elderly, right? It's us. So we probably don't have atrial fibrillation. But if we do detect it, it's a good screening tool on the smartwatch. You would then try to confirm it. How do we know that this is not a biased study by Apple? I'm really into watches. If you know me well, you know I'm like a watch collector and I'm into watches. And I was reading a watch journal yesterday that's amazing. Like Rolex has 30% of the watch market worldwide, but Apple has the other 30%, which is amazing because of this smartwatch. So how do we know they're not biasing this study? Well, they did sponsor the study. However, all the data was stored at Stanford, on Stanford platforms. All the analysis was done by Stanford scientists independently, and Stanford had the right to publish the results regardless if it was a positive or negative study. So I'm fairly convinced by these methods of maintaining, let's say, independence of the study. So what we know is that the Apple Watch then will intermittently, passively detect pulse rate data that could suggest atrial fibrillation. So there's over 200 million smartwatches right now that are being worn by 45% of Americans. So this whole idea of wearables can really be helpful to you as a doctor today. Wearables incorporate AI and machine learning, as you might imagine. They can be used to monitor the patient remotely and potentially help between those in-person visits. Like when you see, let's say you see a patient here in Insight for primary care, and you see the next visit is in 3 months. In between, you can monitor them with a wearable. And it also empowers the patient to engage with their own health data for self-care and can allow you to develop a personalized treatment plan and detect things early. As we go more into some case examples, I'll show you how you could leverage the monitoring through a smartwatch to your advantage to help prevent your patient from coming to the emergency room here or being admitted to the hospital. So just on the science behind this, it's a photoplasmography sensor with light-emitting and light-sensitive diodes that intermittently and passively measure the change in the blood flow in patients. These signals then generate a tachogram over 1 minute, which is then classified by the app as regular or irregular. Because I know you were wondering, how does this actually work? Well, that's how it works. So some interesting things regarding table 1. The distribution was fairly even between women and men. The age in the notification group was much higher because as you age, you tend to be more likely to develop atrial fibrillation, especially in the over 65 group. They had a fairly diverse panel of patients based on their race and ethnicity, which is nice. We don't want a study that's biased on just one ethnicity. And one interesting thing for me that I guess I learned from this subtleties of looking at this data is that patients who tended to have atrial fibrillation were obese. This is just a push for you to encourage your patients from a preventive point of view to lose weight or limit their obesity. They also had hypertension, diabetes, which we see on all of our patients. Some had strokes and TIAs. So I'm going to give you my spin on this. This is my own interpretation of what to do with this data. This is how I use it right now, and I hope this is what you do when you walk out of this room and go up to the floors or to the clinic. So I broke it down into 5 steps. Keep in mind, this is all me. This is not out of the paper. Step 1, I'll do what we did in this room today. Ask the patient, do you have a smartwatch? There's about a 50% chance that they're wearing one while they're sitting there with you. Step 2, have them download the app to detect atrial fibrillation. Step 3, have them notify you if they have an irregular rhythm. Step 4, if they do screen positive on their smartwatch, have them wear a patch for 7 days to see if they in fact confirm on the monitor atrial fibrillation. And step 5, which is the most important part, if it does show atrial fibrillation, start them on long-term anticoagulation and possibly evaluate them for ablation as a cure. So I promised you I'd give a real case that is similar to patients you see all day, every day. And this case is a 62-year-old woman with a long-standing history of hypertension who presents to the emergency room with decompensated heart failure and newly identified atrial fibrillation with a rapid ventricular response. She is admitted for further evaluation and is found to have a left ventricular ejection fraction of 30%, which is thought to be tachycardia mediated from uncontrolled atrial fibrillation. After cardioversion and anticoagulation and guideline-directed medical therapy for heart failure, she's sent home with remote monitoring and receives a toolkit which includes a blood pressure cuff, a scale, a pulse oximeter, and a cellular hub to transmit data to you. This is a really nice flow chart that kind of demonstrates over months a typical patient that you or I might see with heart failure. You release them from the hospital, they're fine, months go by. Out of the blue, they go into rapid atrial fibrillation, they're hospitalized. You control it, you discharge them. They come to your clinic here. They're fine, they're in sinus rhythm. They go to the cardiologist clinic here. They're fine, they're in sinus rhythm. Months go by, boom, they're in the emergency room, boom, they're in the hospital. Rapid rate, you control them, get their heart failure optimized, see you in the clinic, doing fine, see the cardiologist, doing fine, boom, back in the hospital. What we know in terms of a patient like this is like every patient I've had every day for the last 30 years. What we know is that patients like this get admitted to the hospital on average 2 to 3 times per year. You can do everything right and they still get admitted to the hospital 2 to 3 times a year. So I'm going to demonstrate to you today how you can use artificial intelligence to improve the care of such a patient. Hopefully this example of a patient is something you connect with, because heart failure is the #1 admitting diagnosis to a hospital in the USA right after pregnancy. So it's the most common thing you will ever see in your career. So regarding this timeline, the patient is unaware that they're in atrial fibrillation until they're symptomatic. Atrial fibrillation is paroxysmal, it comes and goes, and patients are often asymptomatic. During the outpatient visits, they might be in sinus rhythm. You listen with the stethoscope, they sound fine. Maybe you do an EKG, it's normal. But they still have paroxysmal atrial fibrillation. And when it gets symptomatic, they end up in the emergency room. So these gaps that I showed you on this diagram are opportunities for valuable, actionable intervention if you have the data, which I'm trying to get you to have the data in between. So during the second week of monitoring, the patient's weight goes up. That's not unusual, right? If you follow someone like this, invariably their weight goes up, they get short of breath. Maybe they call you on the phone. Maybe you have arranged home health, like a visiting nurse, and the nurse detects it. So the patient, in this case, had a remote visit with the nurse. The nurse looked remotely at the legs, The legs showed edema. The blood pressure was measured by the patient and was elevated. The patient's on all the right drugs: ARNI, sodium glucose cotransport inhibitors, anticoagulation. So in this example, just remotely, the diuretic was increased and the patient's symptoms got better. Guideline-directed medical therapy was titrated and readmission was essentially avoided. After 90 days of this kind of monitoring, she did not require readmission, had verbalized understanding of her meds. So this is an example of how you might monitor someone remotely. So just in summary, we're switching from atrial fibrillation now to the next topic, which is congestive heart failure. Now, I'm going to share something with you that I really believe will blow you away. It's going to blow your mind. You're like, no, yeah. What I'm going to share with you is you can train through AI an algorithm to look at an EKG right now with no other information and say low EF or not, just by reading an EKG, nothing else. Like you can do an EKG on me right now, show it to the AI trained algorithm, it can tell whether I have a low EF from the EKG. No echo data. You're like, no. I'm like, yeah, okay, so I'm going to show you the studies. The studies are cool because they're in the last few weeks that I'm going to show you. I am always at the cutting edge. So what I'm going to share with you is in the last few weeks, not a year ago, not 6 months ago. So September 26th, New England Journal AI. This is an example of how you can train an AI algorithm to look at an EKG and say, is there hypertrophy, dilatation, low EF, systolic, diastolic dysfunction? I went for a physical exam within the last year to my primary care doctor. He's internal medicine. He was a chief resident that I trained. He's listed in Chicago Magazine as one of the best internal medicine doctors in Chicago. I'm very proud of that. I trained him. He's my primary care doctor. When he did the physical and we were done, he did an EKG. You're like, okay, so what? I'll show you so what. So the EKG is the most commonly used screening tool for heart disease. In this study, they took 90,000 EKGs from 74,000 patients. They basically matched up or trained the AI algorithm with EKGs and echo data. So the machine is learning, right? The machine is learning to detect things on an EKG that correlate with an abnormal echo. A multi-label deep learning model using the EKG as one input and echocardiogram as the gold standard was done for model training. This is like a depiction of what I'm talking about. You're feeding in the EKG information to the model. You're feeding in the echo information. You're training it. Now the AI can read or detect what the echo findings would be just from looking at an EKG alone. So over half of the patients with hypertrophy, dilatation, or enlargement can be detected with EKG monitoring. Now, this was interesting for me. You really only need leads 1, AVR, V1, and V5. You don't even need the whole EKG. Why this is important is, given that you only need those limited leads, wearables can actually be used then to detect the presence of heart failure or a low EF. So EKGs can be a viable method for early diagnosis of hypertrophy, dilatation, and enlargement. But I want to talk also about symptomatic heart failure too. So many of the patients that get admitted to me are in the emergency room with shortness of breath. At the time we see them, we don't know if they have heart failure or a lung problem. So is the cause of dyspnea cardiac or pulmonary? Maybe they've never had an echo here. Maybe we don't have any old history to say that they have heart disease or lung disease. So often in the emergency room, we're trying to determine which one it is, heart or lungs. You can use AI then just by looking at the EKG without waiting on that echo to be done tomorrow or the next day. You can know instantaneously whether it's the heart or the lungs. Somehow I have a feeling Dr. Carilla thinks this is cool. I don't know, though. I'll ask him later. So acute dyspnea is common, right? We see it all the time. In this study, we basically trained the AI to look at an EKG and know whether or not heart failure is present. What's interesting about this is this performed better than BNP. So if you had a choice right now, let the AI look at an EKG or order a BNP, the AI would beat the BNP every time. You're like, no. I'm like, yeah. You're like, I don't believe it. It's true. AI was superior to pro-BNP to distinguish cardiac versus a pulmonary cause of dyspnea. So here's a nice diagram explaining how this was done using transformers. So look, one group had EF pre-training, other had pneumonia training. You had like 40,000 subjects and 77,000 EKGs in the pre-trained ejection fraction arm. So what did they find? AI EKG could be useful in the emergency department, and it could lead to a more tailored treatment strategy. So I don't know about you guys, but when I get a patient like this admitted to me, I have to order the echo, put that order in. Then I have to wait for the tech to do the echo. They do it the next day usually, and then I have to wait for the cardiologist to read it. And that cardiologist might be in cath lab all day. They might not get to read it till 4 p.m. That was my experience. And so I may not have the echo report for 24 to 48 hours or more. And so here, while they're in the ER, I'll know that information instantaneously. I hope you see the beauty of this, how amazing this is. So again, another paper in August of 2023, this is a little older, from the Canadian Journal of Cardiology, also demonstrating you could train an AI algorithm for low ejection fraction patients. All right, so we are 2/3 of the way through my AI and cardiology talk today. We did disease number 1, atrial fibrillation, and you're gonna use your smartwatch on the patient to screen for, detect, monitor their atrial fibrillation. Number 2, your patients with heart failure, you're gonna be able to use an AI-enabled read of an EKG to know what the ejection fraction is instantaneously without waiting days for an echo report. So number 3, or case 3, is a 60-year-old man with substernal chest pain radiating to the left arm. This is the EKG. So I need a volunteer to read the EKG, and it's not hard. So I'm gonna bet that whoever reads it in this, I could call on anyone in this room, I would bet that they will get it correct, even though I don't bet. Let's see, how about, I don't know people's names here, but Dr. Carilla, help me be the bad guy. Call on someone who is able to read an EKG.
Okay, so I will stepwise. This is sinus rhythm. I'll go with the theory for to save time. This patient has a STEMI.
Yeah, it's a STEMI. Tell me more. You're right.
Yes, so we can see ST elevations in these V1, V1, V2, V3. There are electrophilic wave inversions in these 2, 3 AVF. So this looks anterior wall ischemia.
Okay. So You're like, I didn't learn anything new. I know how to recognize a STEMI. But what you didn't know is how to use AI to help you in this regard.
Did he need AI?
And I love Dr. Carilla's question, which is, do we need AI? I think, my wife, Dr. Andrea Slesoritis, and I have this organization that you know about. It's called the American College of Artificial Intelligence in Medicine. And every day we ask ourselves, do we need AI to do this or not? And if we don't, then we don't want to use AI to do this. We only want it if it's helpful, if it makes a difference. So at the end of this discussion of this paper, I'm going to ask Dr. Carilla whether he thinks we need AI or we don't, because he's one of the smartest people I know, so I want to see what his thoughts are on this. So the study is called ARISE, A-R-I-S-E, Artificial Intelligence Rapid Identification of ST Elevation. It enrolled 43,234 patients. The average age was 60. Half were men, half were women. They were in the emergency room. This is why it works, if you want to believe it works. I'm an optimist with AI. This is why it works, because an AI text message was sent to a cardiologist when the EKG was done. Think of how you just eliminated all the delays, right? So the AI is looking at the EKG, saying there's an ST elevation at my end, immediately transmitting a text message to the cell phone of the person that's doing caths today. Can you imagine how you just eliminated such delays with that? All right, you're not buying it. Okay, so this is New England Journal AI, 2024, published on June 27th. So July, August, September, October, November. It's about 4 or 5 months ago. It's still pretty new. So let's look at some of this data. AI EKG interpretation had the high ability to correctly identify positive cases and negative cases. 89.5% for positive cases, 99.9% negative. That's pretty high for the negative cases. It exceeds the conventional automated EKG. So back to Dr. Carilla's point. If we have a EKG machine technology now that always reads it, right? Why do we need AI? Because AI did better than commercial devices. This is next point is really important, which is there was a significant reduction in the number of calling in the cath lab inappropriately. Like, can you imagine if you're a cardiologist, it's Sunday, it's 2 a.m, you get called in with a whole team to go to the cath lab, and you get there and you realize this was unnecessary. Can you imagine how angry you might be in that case? So it made a really big impact in reducing the number of ST elevation MI activations. Let me explain why that would be. I would get called almost every single day by a student or a resident that there's an EKG that shows an ST elevation MI. The majority of the time that was untrue. And the majority of the time it was J-point elevation. But now you're triggering a whole pathway where you're calling in the cardiologist to go to the cath lab. I would always have them send me the EKG. I would look at it. I would say, hey, this isn't ST elevation, it's J-point elevation. But here the AI is reading the EKG instantaneously and making the decision and calling in the cath lab team. So it led to improved diagnostic accuracy, reducing the rate of misdiagnoses. So this is the part where you could, if you were a naysayer, if you were negative, if you wanted to argue we don't need AI, you could say no significant difference was found in hospital duration of stay, ejection fraction, left ventricular ejection fraction, peak troponin level, CK. So why do it? Good question. Well, it did cut the door to balloon time by 14 minutes, from 96 to 82 minutes. It also decreased the EKG to balloon time from 83 to 78 minutes. It also had a high positive and negative predictive value. And there were fewer ST elevation MI activations in patients not requiring emergent angiography. So benefits, decreased door to balloon time. So that's the ARISE trial. So modest or no difference between intervention and control groups on heart failure, EF, but improvement of door to balloon time. So I'm going to throw this back to Dr. Carilla. Based on the data that I showed you, should we use AI for acute MI intervention at this point or not? What do you think? It's just your opinion. There's no right or wrong answer. But I'm curious, given what you do and in terms of critical care management being my guru for critical care, I really want to know what you think.
Well, to answer this question, I was questioning how AI model is able to determine the EF from EKG.
But that's a previous one. That's because it's trained. It's trained to do that by giving it, hundreds of thousands of echoes and hundreds of thousands of EKG. The only value in that is you'll know the EF 2 days sooner if you don't have an old echo. That's the value there. Yeah.
And I wanted to complete. So in order to answer the query that I raised, guess what I did?
You used AI. You used ChatGPT or some similar product. And what did you find?
I found out that AI looks at the QRS duration and the R wave progressions.
Yes.
That's when
That's how it.
time is taken for the QRS actually would determine how strong the heart is.
Nice.
They correlated that with thousands of EKGs in relation to echoes.
Yes.
Determine the ejection fraction for the patient. This is something that we cannot do.
I agree. Yes, absolutely. That's well stated.
Similarly, with acute MI, there will be subtle ECG changes
That are not visible to the human eye. Absolutely. I love your insight into this. Insight at insight. I didn't intend for that, but
from an inside to inside.
right? You got to have some humor in medicine, right? It's good. All right. Well, thank you for that brilliant commentary. I love it. You and I need to have, at least once a month, we should have a conversation about AI and medicine. All right, so take-home points. Number 1, the Apple smartwatch is an effective tool to detect paroxysmal atrial fibrillation. Number 2, artificial intelligence can be used to read an EKG to diagnose congestive heart failure without an echocardiogram. Number 3, AI applied to EKG interpretation of an ST elevation MI can decrease the door to needle time by 14 minutes and eliminate false positives and the need to mobilize the cath lab team. All right, so now this is the fun part. We have some time for questions and answers. And yeah, go ahead.
Thank you so much.
When you state the question, I'll repeat it into the microphone so everyone that's on virtual can hear. Yes, go ahead.
Yeah, thank you for this insightful lecture, first of all. My question is, if I had a patient come in with classical symptoms of heart failure, for instance, right? And AI helps me diagnose the patient with heart failure. Now, per guidelines, we try to start GDMT up front. Now, supposing the cardiologist is not in-house, and AI tells me EF is still somewhat about 40%, do I go up ahead to start GDMT, or I'll still have to wait for the cardiologist?
Okay, this is a fantastic question. Again, I'm going to give you my opinion. There's obviously no fact here. So the question was, if we now have an AI-enabled EKG interpretation saying the EF is low, in your example 40%, or in my example say 30%, 20%, do we need to wait for the cardiologist, or do we need to wait for an echo, or do we need to await further data, or can we just start GDMT immediately? So I will tell you that you should start GDMT immediately. That's my opinion. Yeah, absolutely. I'm a huge advocate of that. My research in AI is specifically directed in heart failure and using it to improve compliance with guideline-directed medical therapy. So I love your question. And yes, I wouldn't wait. I think this is an opportunity to start treatment sooner, decrease delay in starting treatment. So absolutely, yes.
Liable to any consequences of this
Now,
decision.
yeah, so now in all things in medicine, there's risks and benefits. If you want to be 100% risk averse, you'll always delay in doing things, and that's not in the patient's best interest. So again, you would weigh your risks and benefits. There's no correct answer. This is where it's the art of medicine, right? You weigh the risks, you weigh the benefits, you make a decision. Your decision may not be the same as your colleagues, right? It depends how risk averse you are. And you asked me my thought. My thought was just do it, right? Nike. I've worn Nike my entire life. Just do it. All right, yes.
Thank you for the lecture, Dr. Speisman. So I have a question. How does AI induce or reduce bias when it comes to diagnosing a particular condition? For example, someone who's wearing a watch and has, let's say, atrial fibrillation will also be having shortness of breath. And that patient may go into AFib with RVR, but his underlying problem may be that patient is having a PE or something, or some other pulmonary cause. So how does AI differentiate between that, or does it kind of lead physicians towards anchoring bias, or does it reduce it?
Okay, this is a complex question, multi-part. So how does AI reduce bias? Does it lead to an anchoring bias? So what I will tell you in this regard is that for those that are not like practicing clinicians like everyone in this room, the others that are in AI and healthcare space, they are focusing primarily on the question that you asked, which is bias. They don't treat heart failure. They don't treat MI like we do, right? But what can they contribute? They have a lot to offer. So not everyone that does AI in medicine is a physician, as you can imagine. Some are computer scientists. Some are biomedical engineers. Some are in the informatics space. So some are leaders or thinkers in healthcare. So they are focusing their energy on bias. So I will tell you that, and you may have heard me say this before, most of the top people in AI and medicine right now are working on the problem you just asked about, which is how do we reduce a bias in AI? That is like the brilliant minds in AI and medicine. That's all they do. They don't do anything else. I know these people. They are invited to speak at every national meeting. They just fly from national meeting to national meeting, whether it's cardiology or oncology, because the biggest issue right now, the flaw in using AI right now, if you want to say the flaw or the negative, is the potential for bias. So these really amazing physicians and leaders and thinkers, they are building AI algorithms that minimize bias. And so what I can share with you is everybody that works in my AI and medicine space, so to speak, they construct these algorithms up front with the goal of preventing bias. They anticipate the bias before the algorithm is generated. So it is the major focus in the AI and medicine world is bias prevention. I was fortunate. I was recently a professor at the University of Illinois College of Medicine. The data I gathered was really nice because we have an incredibly diverse panel of patients. So when I did my AI and heart failure project, 50% of people in that study were of a diverse population, either African American or Hispanic. So having data sets that are diverse helps to prevent bias. So this is this topic that you threw out at me. Most of the people who are like me speak for 1 hour about that. I won't do that. I'll spare you guys that. But I'm not an expert in that. I'm an expert in what we talked about today. Yes, Dr. Krill.
So ABIM is always behind the reality of physicians. It took them around 20 years after the release of UpToDate to make the exam
Yes.
open book. You can
Right.
use UpToDate.
Yes.
How much longer it's going to take them before we can use AI in our examination?
Great question. I love it. So just to repeat for those that are virtual, Dr. Carilla's question is that the ABIM board exam, eventually they came around to the notion that we're all using UpToDate every day in our practice to look things up. So they allow you to use UpToDate when you take the exam, which I think is good, right? It reflects reality. Like if I'm seeing a patient right now with you guys, or you're presenting it to me in the resident clinic, I'm going to be, okay, let's look this up on UpToDate before we go back in the room, right? We all do that every day, all day long. So now what I'm doing, I suspect what Dr. Carilla is doing, is we don't have to necessarily go on UpToDate, although we will. We also can just go on ChatGPT and use, I use ChatGPT every single day to look up medical information and make decisions. On a different lecture, I will actually demonstrate to you how to do it. But to your point, so if the ABIM board exam allows UpToDate today, which they do, in the future, will they let us use an LLM like ChatGPT? It seems reasonable to me. I mean, we should be testing clinicians in a real world scenario. So in the real world, we have the ability to use ChatGPT in the patient room or up on the floors to make decision points. Why not when we're taking the exam? So I fully agree with you. I think that seems like a reasonable thing in the future.
And I do think that we should evaluate our residents based on how they access information,
Yes.
how much they acquire,
Right.
and how they can utilize their ability to analyze data.
Absolutely.
In making decisions for the
Yeah.
patients.
Right. So back to your point, being a thinker, a critical thinker, if AI is going to give you data, then you then can critically analyze that data. So I'm thumbs up based on your comments. I think it's a brilliant thought. Who knows how long it'll take for ABIM to come along, but I do think it makes sense. When ChatGPT came out 2 years ago, it transformed how we approach problem solving in the world. So I am telling everyone it's a tool like the stethoscope. So I fully support your notion that it could be in the exam room, on the exam with you when you're taking an exam. I think that seems reasonable to me, but I'm sure we can argue both sides, right? Because there certainly is a value in having knowledge in your brain that you learned on your own, so where's the line between looking everything up and, having some fundamental knowledge in your own brain? So obviously, all the great thinkers in history have said the golden mean, finding that balance somewhere in between. So someone else had a question here. Yes?
Thank you for your presentation. I'm not too familiar with AI as of yet, but what are your thoughts on, as this field is expanding and in the field of medicine, do you think more companies, or do you think that there's going to be more databases that people will go to draw information from? And what do you think, how do you think that's going to impact medicine? If people don't know where to go to get information, or if there's more systems that you could use to get that information?
Okay, very complicated question. I'll do my best to recreate that. But basically the question was, will people be going to get their information from companies, or what type of search engine will they use for AI? So at least so I should have started the talk by saying I have no financial disclosures. I run a not-for-profit American College of AI and Medicine. We take no monies from corporations, industry, so I'm not biased in any way by, because you asked about corporations. I myself use ChatGPT for But there are many other LLMs out there, and many of them are better because they're trained on scientific data, not the general internet. So I don't necessarily think that that is the best one to use, but that's what I'm using right now. There are many other LLMs that are out there, but are not necessarily well known. When I surveyed the residents at the different hospitals I teach, that they're not necessarily using ChatGPT. They're using some that are like open evidence, for example, type things. So, which I support, using ones that are more medicine trained. But when you ask about the general public, the majority are using ChatGPT because that's the first one that like over 1 billion people used it in a short period of time after release. So that's what we all know, but I think over time, maybe other companies will get their product out there. What I will tell you is that I've done certification programs at Northwestern, Kellogg, at MIT, and at Harvard. Almost everyone that's in those certificate programs, other than myself, their end game is to start a startup company and make a fortune on this concept. That's not what I'm about. I'm about open source, open access, educate you and others on doing things. So, certainly there's a whole, the business world is completely focused on this in the last 12 months. So you had a follow-up to that.
Sorry, sir. So I didn't think I explained my question properly. So you talked about how EKGs can be read by AI that can be beneficial in certain instances. Do you think, so is there just like one route, there's like one AI that reads the EKG, or do you think that companies will make like different programs that you can read EKG with, and then doctors will have to decide like what is the most, best option?
Yeah, that's a good, I understand where you're coming with. So there won't be one. Dr. Carilla and I were previously at another hospital in Chicago called West Suburban. And one of the cardiologists there, he's currently now practicing in Arizona. And he does CT scans of the heart, imaging. And it's the product, he has one of the most powerful CAT scanners in the world for the heart. And in his institution, they're about to do a randomized trial on AI for CT scans. But where I'm going with this is that the FDA has over 950 AI-approved devices. 10% of those are for cardiology. So my point is there are numerous companies that have patented AI for imaging interpretation, whether it's EKG or echo or CAT scanning. So he's using those. Those are sold to the healthcare system by a brand, whatever brand, and there's competing brands. So we won't all necessarily be using the same brand of EKG reader or CAT scan reader. There'll be competing brands, and there already are. And there's more than one company that has patents on these products. So does that help at all? Or yeah.
So I want to add,
Yeah.
AI models are as good as the data that they were trained on. So it's large language model, meaning that they read what we write. And then the bigger the database that are trained on, the better the outcome. Most of these studies are coming from big institutions like Stanford, they have their own model. Yeah. Alabama has a big one.
Yeah.
Actually attended one of their lectures that presented data. And ChatGPT is not built. Now they say that they say that it is actually more medical, but it's not trained on medical data. You need to access those databases where those models can be trained better on this data so they can give you a better outcome.
Yeah, so to follow up on Dr. Carilla's point, he said, ChatGPT is not necessarily trained specific to medical data. So I do a similar presentations at several other hospitals here with residency programs. And I gave this same talk at McNeil Hospital, which is in Berwyn. And the residents, every single resident in the room said that they were using open evidence, not ChatGPT. So whoever's leading that residency program has got them on board with you Now, I haven't used that one. I don't favor one or the other, but it's just to point being, there are medically trained versions of LLMs that you can use, so just keep that in mind. My understanding is that's trained on the stuff that I like PubMed and Cochrane data and things like that. I don't know if anybody here's used that or not. You may want to look into whether we should promote LLMs to the residents to use that are not ChatGPT, that are trained on evidence.
We presented open evidence in one of the.
You did, okay,
Yes,
good.
I use also Dr. Oracle.
Dr.
Oracle.
Oracle, okay.
It's another good one. It gives you there's a research mode and education mode.
Yeah. So I would encourage you to use one that's trained on medical evidence, because I'm an evidence-based physician. My colleagues are all evidence-based physicians. We firmly believe that if you're going to use these tools, it should be evidence-based. So find one that's good and use it, kind of thing. I mean, our organization is about to publish a paper on all the medical LLMs. So I can't speak to one or the other at this point as being better, but I would encourage you to find one and use it. Other questions? Anyone? Yes?
So I have a question so what is the role of big pharma companies when it comes to AI? I know they are making manufacturing devices which are helping us, but what if companies decide to, let's say, feed AI with the information they have? So in a way, is this sort of benefiting them in the long run? Or do you think, I know it's actually helping the patient. Someone gets an EKG done and AI finds something and they're on these medications sooner than they would be 5-10 years down the line. So in a way, do you think there is scope for these companies to come and exploit this? Or
Okay, that's a great question, John. I'll try to summarize it for the audience. So the question is big pharma exploiting AI for their own economic gain? Is that fair to say? So I'll break it down. So first of all, almost all the FDA-approved AI algorithms are for imaging. So I don't know if we're going to say the imaging companies are the same as the big pharma companies. After this, we'll stop. I know our time is up. So what's out there is imaging companies, so not pharmaceutical. So back to the pharmaceutical companies, the head of AI from Stanford isn't there anymore. She was given hundreds of millions of dollars just to her alone to start a company for drug discovery. And the drug discovery that you can do with AI will shorten the time in a manner that's unbelievable. So I do think patients will benefit tremendously by using AI for drug discovery, and that you and I will see breakthroughs in the treatment of diseases at a rate so rapid and so good that you'll be like, yes, I mean, pharmaceutical companies, they're a business, they're going to make profit, but I do think the benefit to society, to humanity, to patient care is going to be so amazingly good. And, this is, what would I say? We live in a country that's, it's about having business and making profit, and there's nothing wrong with that. So that's my general take on that. But I'm in the not-for-profit category. I'm not going to sell out to industry. I'm going to focus on educating physicians on how to use AI for good. So our organization, our motto is AI for good, and our goal is to transform lives worldwide without making a profit. So I'm a different spin, but yes, most people are going to do what you said, but I do think the world will benefit in really great ways. So I think our time is well up. I'm happy to chat privately with you guys if anyone wants to continue the conversation. And we'll be continuing one of these top lectures next year after the new year, and it'll be on pulmonary and critical care, which I know Dr. Carrillo has some interest in critical care. All right, thanks guys.